Go for it.
Okay. Hi, everybody. So I'm Simona Buoncompagni. I don't know, some know me, some not, but I just started a fellow here in San Diego with Dr. Ross, Dr. Cargo, and Dr. Dufayet. And so I'm presenting the, I was just the one, like most of the time, these RDBM ask you if the SDMA is better than the creatinine in hyperthyroid cats as a, a biomarker for renal function. So I thought it was interesting to just look a few articles. The ability to identify cats with the change in renal function, we know it's very hard when they have hyperthyroidism or at the beginning of the treatment of hyperthyroidism at the end. But that is a very important thing because it can influence the choice of treatment, can avoid the over treatment, and also can improve the quality of life and prognosis of these cats. And sometimes it's important also to intervene early in the course of the disease. So the first article that I'm going through details is the research article 2020. This is a retrospective evaluation of the relationship between symmetric SDMA, creatinine, and body weight in hyperthyroid cats. And then at the end, I just do a little comparison with this other article that was written in 2018. So we know about the hyperthyroidism, that is most common endocrinopathy in feline patients, and is about 6 to 10% in cats more than 10 years old. And unfortunately, chronic kidney disease is a common comorbidity of the hyperthyroidism, about 15 to 49%. Can mask the change in renal function because increase the glomerular filtration rate and because of the reduced muscle mass that these cats present with. The azotemia is normally observed in about 10% of the hyperthyroid cats, and many of these hyperthyroid cats develop chronic kidney disease only, the hyperthyroid cats that has concurrent chronic kidney disease, they develop azotemia about 15 to 60% after the treatment, because the glomerular filtration rate and decrease and the muscle mass return to the euthyroid state, so they increase the muscle mass. So the creatinine is the most common renal biomarker, and unfortunately is influenced by the muscle mass. So that's make very difficult to interpret in hyperthyroid cats, because most of the cats are very skinny and they don't have lots of muscle mass. And that's why the creatinine can remain normal in hyperthyroidism, also if they have an underlying renal disease. So the SDMA was a new biomarker. Now it's not new anymore, but is produced is a byproduct by the intranuclear arginine methylation. So it's the amino acid arginine that contain two methylene groups, and they are symmetric orientation. You can see on the picture. And these are produced by all nucleated cells. The high concentration is in the brain, but is also found in the liver, in the lung, in the kidney, in the spleen, and the small intestine. Why it's considered very sensitive biomarker? We have an early decline, can be sensitive as an early marker of the glomerular filtration rate as 25% in dog and cats, because primarily it's created by the kidney. So over 90% is excreted by the kidney. And then the other important things that is not affected by lean body mass and diet. So about the first article, the objective of this article was to use a big data to describe the relationship between the creatinine, the TT4, the SDMA and TT4, and then it was also observed the change in body weight, SDMA and creatinine during the treatment of feline hyperparathyroidism. So the material and methods, the sample were obtained through the IDEX lab database from July 2015 to January 2017. And a total of 453 126 cats were included, so many results. This slide is it's very busy, but so I try to simplify a little bit. But the baseline feline population was 4,053 126. Then the study group, how they selected this study group, they practically was the cats that they have at least one sample, one blood sample of TT4, SDMA, and creatinine. And this was the study group of 113,535. And then from this study group, there was the hyperthyroid cat group, so that was cats that were between 6 to 25 years old, and they have at least one thyroid TT4 more than 4.7, and then also one SDMA and one creatinine value, and that's were the hyperthyroid cat group. From the hyperthyroid cat group, they selected the hyperthyroid treated group. So the hyperthyroid treated group was the one that the more than one visit as the TT4, SDMA, creatinine measurement, and the TT4 concentration was decreased by a minimum of 2.5 and be less than 4.7. The problem that we have is with this selection that unfortunately they didn't know the individual therapy for each cat, so the therapy was unknown. But also in this hyperthyroid treating group, the pre-treatment visit, the first time the TT4 has to be more than 4.7. We know that one from the hyperthyroid cat group before, but the post-treatment visit was maximum 120 days, so we're not looking after the 120 days. The other visit from the pre-treatment visit, the TT4 has to be less than 4.7 with a minimum decrease of 2.5 from pre-treatment. So it's a little bit complicated, but that was how they selected the whole group. And then there was a control group, and in this control group, there was these cats has to have at least one visit where the thyroid, the SDMA, and creatinine were measured, and the TT4 has to be between 0.8 to 2.3, so more than 0.8 and less than 2.3. And now you can go. That's it. I'm joking. The time. So between pre-treatment and post-treatment was separated in 30 days. So it was 1 to 30 days, 31 to 60, 61 to 90, 91 to 120. Like I said, they didn't check over the 120 days. These were used as a time points for the comparison for the SDMA, creatinine, and for the body weight. Statistical analysis, that was really complicated, and I'm not going even to mention because they use so many different statistical analysis, and for sure they were much smarter than me to do all this. So I just wrote, but I'm not going to mention it. The results. So we have here, first of all, the first results they want to achieve is the SDMA and creatinine were compared to the TT4 of the entire study group. So this you can see two box plots. The first one was the creatinine, where you can see that the increase of TT4 concentration correlates with a decrease in creatinine concentration. Instead, in the second one, the SDMA box plots, the SDMA concentration did not significantly decrease with the increased concentration of TT4. So what does it mean? That, as we know, but it's nice to have a confirmation, that the SDMA is more resistant to the effect of reduced muscle mass and increased glomerular filtration associated with increased TT4 concentration than is creatinine. So, and then they did they want to find, they did another comparison. So the SDMA and the creatinine were compared to the control euthyroid group. So you can see here that there is the statistic that they used, the Mann-Whitney U test, and the p-value was minor than 0.001. And the whisker represent 1.5 times the interquantile range. So from this, you can see that the cats with hyperthyroid had lower concentration of both creatinine and SDMA compared to the control euthyroid cats. You can go, I don't know how to point, but you can go, you can see here. Oh, there is I don't know, doesn't work. Instead, the creatinine and SDMA concentration increased significantly between the pre-treatment hyperthyroid state and 30 days post-treatment. And this indicates the resolution of hyperfiltration and reduction in glomerular filtration rate. So, and then the creatinine was compared between the pre-treatment versus the post-treatment. In this case, they use a Wilcox-Sinyan-Rankin test. I don't know even how to pronounce, but the p-value was 0.007, and the whisker was always represent the 1.5 times the interquantile range. So the results was that the hyperthyroid cats has a significantly lower creatinine concentration pre-treatment, and 30 days between the, let's say 1 month, the second month, and the third month, probably is easy. That is consistent with the previous observation, but like I said, it's nice to have another confirmation that the kidney dysfunction may be masked by the hypermetabolic state of hyperthyroidism. And the reduced muscle mass results in reduced production of creatinine. In fact, only creatinine concentration continued to increase for months after the glomerular filtration rate should have stabilized. So that is very important to understand that the muscle continue, the muscle continue to affect the creatinine even 3 months post initiation the therapy of hyperthyroidism. And I know there are other studies that said was I'm not mentioning here, but was 1 month. But here you can definitely see even 3 months post initiation, the hyperthyroidism can be affected by the muscle mass. So, and then the SDMA was compared pre-treatment and post-treatment. You can see the diagram here. In this case, the p-value was less than before. And the conclusion, the results was that the hyperthyroid cats has a significantly lower SDMA concentration pre-treatment, but was not different in concentration through the remaining treatment periods. So the lack of a significant difference between the SDMA concentration at 1 month and the other 2-3 months indicates how minimal the effect of extrarenal factor has on the SDMA. Especially those that we said before, the muscle wasting, and subsequently also the weight gain during the treatment of the hyperthyroid state. So I know that at the beginning I mentioned about the creatinine and SDMA, but this study also looked at the body weight. So that the body weight was compared from the pre-treatment with the post-treatment. Always the 1 month, 2 months, and 3 months. And so a significant increase in body weight were seen subsequently to treatment. Body weight increased an average of 0.4 kilograms by 4 months post-hyperthyroid treatment. So that is important also to know because, you know, some of these clients, they want to see the results immediately. So sometimes, you know, we need to have some time. So this increasing weight, what demonstrate that the catabolic state is practically is what changed the muscle mass in the cats. So that's with the time, this catabolic state improve, and so the cats can gain weight. So there were some study limitation. There were some incomplete results, irregular time points, testing of 6 patients that they didn't know, especially the 6 patients that we don't know other comorbidity, other disease that they were underlying. The body weight was used as approximately as a lean body mass, and for sure we know there is a difference between these two. Another limitation was the USG was not incorporated. And then the incomplete treatment or not treatment, like I said at the beginning, they didn't know what the treatment was, so was not included. And then, so what they recommend that the next, study will be considered a subgroup of hyperthyroid cats diagnosis with renal dysfunction. So the conclusion of this study support that the SDMA is less affected by extra renal factor than creatinine in hyperthyroid cats before and after treatment. So we had the kind of an idea that this was happening. We knew, but it's nice to have a study that confirmed, and so we can, be more clear to the whatever. So this is another article that I want kind of to compare, and I'm not going to describe it so details like the first one, but so I start with the conclusion. So this article is evaluation of serum SDMA concentration as a marker for masked chronic kidney disease in cats with hyperthyroidism. So their conclusion was that the SDMA, in this case, they look at the USG, may help identify and predict hyperthyroid cats that are likely to develop azotemia after the ionized 131 treatment. Another thing that they found in this study, that the cats that they became hypothyroid after the 131 treatment are more likely to develop post-treatment azotemia, a high SDMA that cats made euthyroid. So from this table, we can see what predicting the what biomarker predicted the post-treatment chronic kidney disease. So we can see here we have some values. So we have numbers and we have a specificity and sensitivity. So the SDMA that is higher than 14 is in untreated hyperthyroid cat is highly specific, so 97.7, but low sensitivity, 33.3. So if we lower the cutoff of the SDMA, so instead of 14, we go 12, that results in an increase in sensitivity and a slightly decrease in specificity. So you can see that the sensitivity go up kind of double from 33 to 64. Instead, the specificity just decline a little bit from 97.7 to 93.2. So we can definitely, doesn't matter what the cutoff we use, but the SDMA has always higher sensitivity compared to the creatinine, as you can see in this table. Then, as I said at the beginning, they also looked at the USG. So it was really interesting to notice that the pre-treatment USG of 1035 was fairly sensitive, and 92%, and moderate specific, about 71% for predicting azotemia. So will be now wonderful to put all these three together and have, the best biomarker. But unfortunately, they tried to do combining all these results, and did not dramatically improve the predictive performance of these analyses. So that was something that for sure they were looking into. But when they combined these results, they found, as I said at the beginning, that the cats that became hypothyroid after the 131 treatment are more likely to become azotemic than cats made euthyroid. So in human, the influence of hyperthyroidism in human patients with the thyroid disease without concurrent renal disease increase the SDMA concentration are reporting both hyperthyroidism and hypothyroidism. So they think that is not related only to the glomerular filtration ratio, but is related to the hypothyroidism. So there is a connection, between the thyroid disease, hypo or hyper, and SDMA. Independent from the glomerular filtration rate. So in this study, they tried to look at these two and see if it was true in cats. Because the SDMA metabolism in cats was not really known. And they found that the change of this in SDMA concentration in these untreated hyperthyroid cats primarily affect the change in glomerular filtration ratio, rather than the direct effect of the hyperthyroidism. So different from human, at least in this study. For sure, probably we need more studies, but in this study, there is no correlation with the thyroid disease at SDMA, but the SDMA is related to the glomerular filtration ratio that increase with the hyperthyroidism. So if I answer the initial question, is SDMA more reliable biomarker of renal function than creatinine in hyperthyroid cats? I think I can say yes, until probably we don't have a better one, but for now we can definitely rely on SDMA more than the creatinine. I think I went too fast. I went very fast. I'm sorry.
Don't be sorry, that's great. That was really excellent. Thank you, Simona. One question, I guess. Well, I guess before I ask my question, I'll see if anybody else has questions or comments that they want to open up with. I'll keep an eye on the chat, but go ahead and you can turn on your mics as well too. But one question I have kind of to the group is, how often are people recommending, not necessarily for I-131, but in terms of management, the cat who has CKD and hyperthyroidism, how often are people recommending, some like more of a partial control of the hyperthyroidism, keeping their thyroid level at maybe 4 or 5 so that they're not as azotemic to try to kind of ride the line? Or are people more so recommending treat the hyperthyroidism, get that out of the way, and then deal with the CKD that you're left?
I think in my experience, I see the difference between like when I deal with the RDVM, my experience, they go very they want to have the thyroid level back to the lower level. So to normal, even lower than normal. And sometimes I always tell them, you don't need it to go so low because of the possible chronic kidney disease or because of the underlying kidney disease. So I think in my experience, the RDBM tend to treat this hyperthyroid like in the, how you say, a lot, that they decrease the thyroid, the TT4 to the lower end. Personally, I don't, so I like to keep higher a little bit, like in the higher end. So, but that is my experience. I have, and most of this question comes from the RDVM, because and then they develop the chronic kidney disease, and then they ask you what I can do to prevent that. So, what kind of test I can do to prevent that? And then they ask, oh, is the SDMA is better? So, and then they look at the SDMA, and oh, it's normal, so I can do it. I can treat more, And I try to explain that it's not really like that. So, but yeah, that's my experience. I don't know if I answer your question.
Yeah, no, definitely. I'm curious to see what other people might be doing. I personally, I usually try to just treat the hyperthyroidism, and I like to get it out of the way as a variable and then see what magnitude of CKD I have left and treat that. But you know, there are those patients that already have substantial CKD that I think if I'm going to leave them a bit hyperthyroid, to me, I kind of approach that almost like hospice care, you know, that, okay, we're going to, I know that I'm going to toast the kidneys by leaving this cat hyperthyroid, but I feel like if I drop their GFR back to their baseline, they're probably not going to eat. The owners don't want to do an E-tube. The quality of life is going to go down. So it's pretty rare that I find myself in that situation where I might leave them just that smidge hyperthyroid. I think it's a question we get all the time, and almost always my answer is to just treat the hyperthyroidism and then manage the CKD separately. Yeah. But you know, there are occasionally that scenario that they're just going to feel really crummy once they get back to their baseline GFR.
And, and for sure, I treated the hyperthyroid. There is for sure a range, so I like to keep in the high range. I don't like to keep it to the lower range. But yes, I definitely don't like to keep the cat's hyperthyroid, and also in my experience, I don't go. Depends if you do the 131 or you treat medically. For sure, there is a difference there too. Right. But yes, I agree with you. I think they feel miserable, you know, when we decrease the TT4 too much, but in the meantime, you don't want to keep them hyperthyroid to keep happy the kidney. So it's kind of a difficult balance, definitely.
Sure. And it seems like people agree, Claire and Rebecca both said the same thing, like just trying to prevent them from being hypothyroid is probably the biggest thing, but treating their kidney disease it probably makes the most sense. Yeah. I can't say the last one that I've seen who had a creatinine of like 5 before we started treating their hyperthyroidism. If anything, they usually have a creatinine of maybe 2 or some, maybe 3, but they're usually not super like stage 12 CKD cats before you start treating their hyperthyroidism, in my experience, for the most part.
Yeah, and I completely agree with you there. You know, I don't think we want to give a number because all our like vets want to, sometimes they want like a recipe, you know, if I have these I can do this, if I have these I can do the other one. And I think the hyperthyroid, the chronic kidney disease, we know how complicated it is, the balance between the two. So sometimes it's really hard to tell, oh, you can do this if you have the SDMA, so at this level you can treat at this level. So but there are multiple factors to consider, so that's what I think. But for what I saw from this study, for me was the things that I really liked. It was like, you know, the hypothyroidism that we create sometimes by treating these cats, because we want to go at the beginning. I don't know, at least when I started my residency, the treatment was much higher, the dose of iodine that they use now. I think it was about 3 and now it's about 1.5. So they changed the dose a lot. And I think it made a difference, because I remember when I was treating some of these cats, they became hypothyroid. And that's now the study suggests that it is even worse because of the what can create to the kidney. So I think that is a good improvement. I think so. So that they didn't treat it so strong, so fast, that they reduced the dose.
Yeah, I totally agree. And Cedric points out that keeping them somewhat hyperthyroid is detrimental to the kidney long term, and it doesn't mean that their CKD is gone, and that's 100% true. And that's what I tell vets when I'm talking to them, that the only time I would leave them a bit hyperthyroid is if it's hospice, if that's the only way that the cat's going to keep eating, and you know that you're sacrificing the kidneys. But in terms of quality of life, if they're anorexic with a creatinine of 6 and a T4 of 2 versus eating with a creatinine of 4 and a T4 of 4, you know, maybe there's the rare cat that might have a better quality of life for a short term, but that's not a very good sustainable option overall. So generally, I recommend, as what everybody else has been saying, to try to treat their hyperthyroidism, prevent them from becoming hypothyroid, and then see their CKD that you're left with thereafter.
Exactly, that's is my point. I think from all these articles, that's what really came out, that to prevent to become hypothyroid, you know, treating the be in the range, in the higher, I like in the higher range, highest range, but yes, I completely agree with you. Sorry, I was too fast. I thought it was long. I got in 30 minutes. Boom. Like,
now you have to just make stuff up for the next half an hour. It's fine.
I know. Sherry was like, "Oh, you will never go through this. They have no time." And you know, I'm Italian. I speak really fast, so I need to calm down here.
Another question I'd love to see what the group says is how many people are recommending, if they are sending a cat for I-131 treatment, are people still recommending a course of methimazole or diet or reversible medical therapy for a couple weeks to determine the magnitude of CKD that's there prior to doing I-131, or are people just sending them for I-131?
Yeah, and that's a good question. Like, I was taught to treat it for 2 weeks. And then when I read some other article, Peterson, I think, if I don't make a mistake, but he recommended longer than that, absolutely longer. So that was like, wow, for me. I have these 2 weeks in my memory. Unfortunately, I don't have it now. I'm not treating with hyperthyroid cats with the 131. I don't have, so I don't have any more experience. But during my residency, yeah, we were doing 2 weeks with medication and then the treatment. The one that I read, he was recommending, he recommends longer than 2 weeks, but I don't know anymore. I don't have too much experience right now.
Yeah, and it's interesting to see what people are saying in the chat, that there's a little bit of variety. It seems like people are still interested in knowing what happens with the methimazole trial. But, you know, I think that if we're agreeing that we want to treat them, if we want to treat their hyperthyroidism, regardless if they have CKD, personally, unless I'm dealing with an owner who says that if there is chronic kidney disease, they don't want to do I-131, even if it's still our recommendation. For me, I find that it's less important. You know, if I'm going to treat them and see that they have CKD, but I'm going to still send them for I-131, I would just recommend I-131. Personally, I don't feel like I really need to see a methimazole trial unless they're those cats that are starting with a creatinine of maybe 4 or something like that before you start treating them. And even with my own personal cats who have been hyperthyroid, I haven't bothered with methimazole. I've just done the I-131 because I wanted to do what we just said, treat their hyperthyroidism and then deal with any CKD that was left behind. But I know a lot of the people who are giving I-131 who still often want to see that in order to feel more comfortable, I guess maybe just talking to the clients and having that discussion. But it's interesting to see what people are reporting. It seems like the holder of the I-131 might be the gatekeeper in terms of whether they get the methimazole trial or not.
Yeah, I honestly agree with you. I don't have really an answer there, because that makes sense of what you're saying. That yeah, I don't know. That's is a good question, honestly.
It's interesting. They're really excellent comments on the chat. I'm just trying to keep up with all of them, but
thank you, JD, for doing that. I think I can look now too.
yeah, sure. No, it's great. People are really saying excellent comments, and feel free. Certainly, you can turn your microphone on too and chat as well. But you know, it just seems like some dogmatic things. Like, we always need to do the methimazole trial before I-131. We say that with one breath, but then we also say, yeah, but we want to treat them even if they have CKD in the next breath, which to me then makes me question, well, what's the utility unless you have one of those cats, which I think are generally pretty uncommon. As Sherry said, like maybe if they're a stage 3 or stage 4 cat, that might be more important in terms of their CKD to do that trial. But it's pretty rare that you're going to have a cat with a creatinine of 0.9 that's hyperthyroid, and their BUN's not a million already, and their SDMA is 50 already. That's going to go up to a creatinine of 6 post I-131, and they're just going to fall off the cliff. They happen occasionally, but they're pretty darn rare. So I'm less eager to do the methimazole trial and just send them for treatment. And we have some I-131 practitioners here who are pretty comfortable with that, as long as we have that conversation and we've talked to the clients about kidney disease. But they're happy to do it as well too. So I find myself doing less methimazole trials prior to I-131 because, frankly, I'm probably still going to go forward with
the matter what. Yeah,
exactly.
Yeah, and I agree with you, honestly. That, at the beginning, just they told you that was 10 years ago. They told me like, then you take for kind of okay, but then you realize, it's really worth it to do it. Yeah.
Rebecca brings up a good point. If they're not going to get radioactive iodine for 4 months, then yeah, they should probably get treated as you're waiting. So yeah, I wouldn't withhold treatment if it's going to be prolonged before we can finally get them in. But if it's pretty reasonable to get them over and get them treated, if that's the option, then I usually don't end up giving them the methimazole trial, because for most cats, because they're probably going to tolerate it fine. They're probably going to have a bump in their SDMA and creatinine. They'll probably tolerate it, and I'm probably still going to recommend I-131.
Yeah. I cannot see the chat.
Seems like we might need more places that do I-131 around the country, because it seems like the wait time is sometimes several months for a lot of these places, which is which at that point you really have kind of no option in terms of trying to keep them in a good place before they go.
Yeah, in Oklahoma they had when I did my residency, then they discontinued it. So when I was working as an internist in Oklahoma, I didn't have any place where to send. I think there is now one place in Tulsa, but and she's a practitioner that she does, I think. But yeah, it's hard also to find the place, and it's not easy.
So Pierce asked if everybody is stopping the methimazole prior to giving I-131, or are people keeping them on methimazole right up to the point at which they're receiving the I-131?
I personally stop. Yeah.
And I guess I do whatever the person who's pushing the I-131 wants, and I've seen it both ways. I've seen where they don't care, and I've seen where they want them off of it for a week or something before, to make sure that there's enough uptake of the iodine. But it seems like there's a bit of variability. Some people are certainly saying like 2 weeks, 1 week, but I don't know. Does anybody have any references that they can pull from their top of their head from evidence for that? Because I recall people talking about decreased I-131 uptake in patients that were still receiving methimazole up to the point that they were administered the I-131. But I guess I personally never evaluated that literature or read anything to know if that's just a myth, or is there actually anything to that? Because it seems like there are some people who don't necessarily mind giving I-131 if they come in still on methimazole.
I don't recall it either. Do you remember? Yeah. and I didn't look into that.
Yeah, it's just one of those things that I've heard, but I don't know if I should believe it because someone told me or believe it because there's some evidence at the end of the rainbow.
No, actually, I was going to try typing it out, but it's going to take too long. There's some very old literature back around the mid to late 80s, maybe earlier 80s, that looking at how iodine is metabolized by the thyroid, and you know, brought in and out, and the effects of methimazole. And so there really is, you don't get as good iodination of the thyroglobulin molecule, and that's what people were concerned about. But you know, those are really early studies, and I don't recall seeing anything recently to even as a repeat of that.
Mm-hmm.
So if you did a current lit review and you only went back 10 years, you probably wouldn't find those articles.
Okay. Just, yeah, it makes sense why, honestly, but.
And it's interesting because from the chat, for what people are saying, there's certainly some places that stop for 2 weeks. You know, Jessica points out that some of those cats go nuts during that 2-week time period, that they're back to being bonkers hyperthyroid cats during that time period. Some places might stop for a week, other places don't stop at all. And those places that aren't stopping or only doing 1 week versus 2, it seems like you still hear the same success rate of like 95%, give or take a couple percentage points, from almost every institution that I've talked to about I-131. So I'd be curious to see in a more objective fashion if people are seeing that if you're not stopping the methimazole or the YD or whatever you're doing beforehand, that you are going to have altered outcomes, that the therapy won't be as successful. My inclination is that I don't think these places are seeing the results not be as effective, but again, that could just be people saying what they hope and maybe not what actually exists from the data. I'm happy to know that there is that study from the 80s though, and it's not just a myth that I've been believing for quite some time, that there's at least some evidence down at the end of it. Mary, do you guys do I-131 at Tufts?
Wait a minute, I have to unmute. No, we don't. So we have to ship them out.
Yeah, it seems like there are.
And there's one place in Mass, and then there's another. We used to do it down at our Walpole facility, but we don't do it any longer there. So and there's a place in Connecticut. So we kind of have to we have to kind of figure out where the owners are willing to travel to from New England.
Right. I remember during my residency at Wisconsin, I forget the states, but there were some Midwestern states that just had really restrictive laws in terms of how radioactive the cats could be before they were allowed to go home, where in some places they had to board for like 2 to 4 weeks afterwards. Like it was a long time. And we had seen some of these cats that they were coming from a couple states away, because you know we would do it on a Monday, we'd send them home probably on Thursday or Friday, but in their home state and county, those cats would have to be essentially med boarded for almost a month afterwards.
Yeah, I agree with you. Was one case, it was 2 weeks the cat was there because he was yeah, and you have to measure every day, and yeah. Another 15 minutes. Okay.
Reading through, and the point that Claire brings up is really interesting, that there was no difference found in response to treatment when people were discontinued, and a shorter discontinuation is preferable in most human people. That's really interesting, because I think again that might fit with what anecdotally, it seems that not stopping it, it seems like these cats are still overall well controlled. Personally, I don't think I've ever had a cat that I had to redose where it was not successful. My own personal cat became hypothyroid, but that was the only, I guess, failure of it not being 100% successful, is it was too successful. But personally, I don't think I've ever had a patient that it didn't correct them and we had to redose them. Are people seeing that frequently, that they're having a number of their patients that need to get a second injection because they were underdosed?
During my residency, I got one patient that has to be redosed. Yeah, that's
Yeah, I've had one or two, but they've usually been really hot carcinomas that were huge. And so whether it was technically an underdosing or just needed, pure volume of tumor that was causing it.
Right. Well, it seems like from the response that they're out there for sure, that some of these patients don't respond. Our local facility, we don't do it here at Friendship, but our local specialty clinic that does actually doses them based off of their thyroid scintigraphy. And there's some more recent literature showing that adjusting for the actual volume of the thyroid gland and its uptake might have better outcomes. And so they seem to be pretty successful. We had this really arbitrary algorithm at Wisconsin where it was based on the size of their nodule, how clinical they were, what their thyroid was. And at the end of the day, it was a resident kind of guessing how many millicuries they wanted to give. And it's kind of nutty that that's how it was, but that's how it was. And I'm sure it probably still is in some places, but you kind of just felt like, well, the algorithm was 2.5. I'm going to go with 2.8 because that's how I was feeling today. So it's nice to know that there are more objective ways of calculating the dose of I-131 than what I was doing. So thankfully to cats, I'm no longer giving I-131 personally.
Yeah.
But I look forward to seeing Rebecca, one of your residents, coming out with that literature. That'd be interesting to see what factors might be there to predict the dosing failure when it's seen. Anybody else have any questions or comments about hyperthyroid cats? CKD, treating them, managing them? I think Andrea had a question way back in the beginning if they looked at BUN as a biomarker, and I think the studies that you were referencing, Simona, did not choose to look at BUN, right? They were just looking at creatinine SDMA and specific gravity. Is that correct?
Yeah, correct. Correct. Sorry, I was trying to look at the chat that I can still not see. I don't know why. Oh, okay.
No, that's okay. There's a lot of chat today, which is awesome, but it means you have to go back about 12 pages to get back to the beginning of it, which is terrific. It's great to have all that communication.
Yeah, try to help me to put the other half an hour.
That's great.
I don't have too much experience with the talking, so.
We'll have to give you 2 topics next time. You get 2 papers.
Exactly, you gave me too fast.
Oh, well, thanks, Simona. That was really excellent. And thanks to everybody for coming as well, too. We can certainly wrap up a couple minutes early today. The next session that we have will be in 2 weeks, and Dr. Summers will be presenting a discussion on laser ablation versus surgery for the treatment of ectopic ureters in dogs. So I'm excited for that one. We do have a couple presenters that have been signed up over the next couple sessions, but we're still certainly looking for some presenters for one date in September, and then October throughout the rest of the year is wide open. So if you are interested in presenting, please shoot me an email, let me know, or You've probably received the email with a link to the spreadsheet more times than you wish to from me. Just go ahead and sign yourself up. But email me if you have questions, or I can do anything to help out with it. But certainly we'd love to get some additional people on the schedule. We have some cool topics coming up, the ectopic ureters, like I mentioned, antiproteinuric therapy, contrast-associated AKI. So I think we have some really great discussions in the future, and I think these have been really fantastic so far. So thanks everybody for presenting and for coming. It's been great. So I really appreciate all your work, Simona, and look forward to chatting with everybody in 2 weeks.
Thank you, guys.
All right, well, I'll go ahead and I'll send out the sign out sheet one more time to everybody, but otherwise I'll go ahead, we'll stop the recording and we'll close the session for today.